Good afternoon. Welcome and thank you for joining us for today's HIS Talk webinar, Succeeding in Value-Based Care via a Technology-Driven Approach. It's brought to you by Health Fidelity. I'm Lori from HIS Talk and I'll be moderating. We have two speakers today. First up will be Adele Powers, MD. Dr. Powers is the Senior Clinical Advisor at UPMC Enterprises. Joining her will be Adam Gronsky. Adam is the Director of Advisory Services at Health Fidelity. And with that, I will turn it over to you, Dr. Powers.
Thank you very much, Lori, and thank you to all of you for joining us today as we talk about how to succeed in value-based care using a technology-driven approach. As Lori mentioned, my name is Adele Powers, and I'm a geriatrician at UPMC. And while I still see patients, for the past 5 years, I've been involved in risk adjustment for our UPMC physicians and our health plan. I am joined by Adam Gronsky from Health Fidelity, who will be explaining the technical aspects of our discussion today. And we hope to show you how technology can help providers succeed in risk adjustment, which is the underpinning of these new value-based care models. So today, we're talking about how value-based care is changing that healthcare landscape. We have MIPS, we have APMs, shared savings, ACOs, and many other versions of value-based care. But specifically, how do these new value-based payment models affect physicians and other providers who've been used to the fee-for-service methodology for so long? And really, how can providers succeed in this new world order? So today, our goals are to discuss how understanding risk adjustment is critical to succeeding in value-based care. Specifically, using technology such as natural language processing can help providers when they're doing their risk adjustment assessments. Finally, I think it's safe to say that most providers and physicians rely on data, so having access to advanced analytics is also critical to monitor your performance and to give feedback to your providers. So let's start with a poll question. First, how are you taking on risk? So please select one on your screen and hit the submit button. So are you taking on risk with commercial or private contracts with a payer partner? Do you have government-sponsored risk plans, both, or no risk plans at this time? Please select one, and while we're waiting for that to happen, I can share that our experience at UPMC is that we share risk primarily with our payers, but we also utilize risk adjustment for our MIPS performance. And utilizing natural language processing, we've been able to generate millions of dollars in savings, which is then transferred to our providers as a bonus payment. So I see the quick poll says that it seems to be that the majority are utilizing both commercial or government-sponsored risk plans. That's very interesting, Adam. I think that'll give us a little bit more of a perspective on what to share. So what is value-based care? In the past, it was very straightforward. A physician or a provider would see a patient and then bill for the service. Unfortunately, this model encouraged frequent visits. So the goal has been to change from a system that rewarded volume to a model that rewarded quality care. So this shift is reminiscent of the major changes that providers had to make to accommodate the ICD-10 conversion in 2015. So not only are providers expected to provide quality care, they're now being expected to document all clinically relevant conditions using the most specific diagnosis code available. And a recent survey showed that physicians are increasing their participation in value-based models, with the most recent data from 2016 showing that 30% of physicians are involved in value-based care. And considering our poll question, it seems that many of you who are listening are also involved in value-based care, and we expect these percentages to increase over time. So using data from CMS, this slide shows that in 2016, over 90 million US lives were managed in risk-based programs, and that number is only increasing, and they expect it to increase by 15 to 20% annually. This slide only demonstrates a few of the models, such as Medicare Advantage, the ACA exchange plans, Medicaid and Medicare ACOs. And look at managed Medicaid, it's by far the largest enrollment. But underlying all of these models is the concept of risk adjustment. And Adam and I are going to go into detail about risk adjustment and illustrate the different rules that providers need to know. But the challenge with understanding these risk-based models is that they do not use the same risk adjustment rules. So the key for a provider is to understand which populations they are being affected by risk adjustment, and then to understand the risk adjustment model for that specific population. But first, how do we define value? So a common representation that many people see is that value is the net of quality and outcomes divided by cost. But ideally, the goal for value is to reduce costs and improve care. But how do we define cost? And that's where risk adjustment comes in. And I'm going to turn this over to Adam to address.
Yeah, so before we really dive into understanding cost and the implications of risk adjustment on cost, I thought we would come up with a common analogy here that really looks and assessed the 432 Medicare ACOs and their 2016 overall performance. Basically, 31% of the Medicare ACOs had generated savings. And what does savings really mean, right? Savings means that you are providing value, providing efficient care in accordance with the risk that is carried. And we will talk about that as we progress through the webinar today and really define that as a measure of efficiency. And one thing that is really not surprising that comes out of this information is the stratification of the risk score to the generated savings that was experienced in these 432 Medicare ACOs. So those ACOs that had a risk score greater than 1.1 created an average beneficiary savings of $435 per beneficiary per year. Those with 1.0 to 1.1 risk score, $176. If you were less than 1.0, it is equivalent to $104 per beneficiary per year generated savings. So if we step ahead to begin to look at the mechanics of this, really what you're seeing here is the scale of efficiency and the ability to generate savings is on a scale of expected expenditures, which are in fact risk adjusted, compared to the actual expenditures. So there's two ways to improve the overall efficiency of care that is being provided. One way is to reduce your overall utilization of care and unnecessary care to reduce those actual expenditures themselves. However, the opposite could be true too, right? The ability to actually represent and accurately and completely represent the overall expected expenditures in accordance with the disease burden of your population. As that increases, so does your efficiency. So as we look at the model here, right, there's a time, and depending on what value-based care arrangement you are in, there's a historical performance measure that has been experienced over time. This could be cost, this could be other equations that you are considering. At a point in time is the launch of the value-based care arrangement itself. And so they use the historical trends to actually predict what the future of this population is going to look like. However, if you keep your risk score at a static level, right, in accordance with your historical trend, you are perceived as a low efficiency provider. Now, is that due to the inability to actually control the cost, or is it due to the inaccuracy of the risk adjustment process itself? This next slide is really looking at, well, what happens when you improve the risk capture itself by 15%? We have not modified or affected the actual expenditure of care. All we have done is actually looked at what are the overall expected expenditures in accordance with the direct reflection of the disease burden of your population. And now we will get into the concept of how does technology fit into this process that allows you to make sure that you are accurately reflecting this risk, therefore perceived as a highly efficient provider.
So now you see that risk adjustment utilizes a risk score that determines our cost efficiency. So now I'm going to review some basic concepts of risk adjustment. So this slide illustrates the different clinical and demographic factors that are used to calculate the HCC model. So the demographic factors are not something that providers can influence, so providers need to focus on the clinical characteristics of the model. HCC stands for Hierarchical Condition Category, which means that there are specific diagnoses that are used to calculate the risk score. These diagnoses are in a hierarchy where one diagnosis could potentially trump another diagnosis. There are specific rules regarding an acceptable location of service or an acceptable clinician type, but it may surprise providers to know that clinical notes from social workers, physical therapists, or psychologists can also be used in risk adjustment. There must be a face-to-face encounter as defined by CMS, and every diagnosis has to be documented yearly. The joke goes that even for conditions such as an amputation, the provider must document and put the diagnosis on a claim every year, or essentially that level of risk goes away for that patient. But finally, providers have to show evidence of MEET, that you have monitored or managed, evaluated, assessed, or treated this condition in the current year. Looking further at the risk score and how it predicts the individual beneficiary's relative risk, you can see that if you have a risk score of 1, then you're expected to have average costs. If your risk score is less than 1, then you're expected to be healthier than average, and it should cost less to care for you. But if your risk score is greater than 1, then you're expected to have higher than average cost. Now, how do we calculate that risk score? We take the sum of the demographic factors plus the sum of the HCC coefficients, and each specific diagnosis carries a coefficient, as well as any interaction factors. And I'm going to show you an example of this. Remember the slide earlier regarding the performance of the Medicare ACOs. The ACOs that had the highest risk scores were the ones that were able to generate the greatest savings. Once you have your risk score, you then multiply that by your base payment rate to get your risk adjustment payment. So let's look at an example of a risk adjustment calculation using a typical outpatient provider note. The good news is that providers do not have to write an extensive note. They just need to show that evidence of MEET, that they've monitored, evaluated, assessed, or treated the condition. So here, Mr. Jones is a 75-year-old male who presents for follow-up of heart failure and diabetes. The key here is that the provider has linked the diabetes to neuropathy, which will increase the diabetes hierarchy coefficient to the level of diabetes with a complication. He has also specified the chronic systolic heart failure, which makes the coders in the room very happy. But in the risk adjustment world, even an unspecified code of heart failure does count. Let's calculate the risk score now. Remember that the demographics are determined by CMS. So here we have a 75-year-old male living in the community on Medicaid who has the chronic systolic heart failure and diabetes with a complication of neuropathy. Both the HCC 18, which is the diabetes with neuropathy, and HCC 85, or the congestive heart failure category, have the same coefficient of 0.368. However, the presence of both of these conditions will allow another additional interaction factor of 0.182. So the total risk score for Mr. Jones is 1.446, so he is expected to have higher than average expected costs. But let's say that Mr. Jones develops a stage 4 pressure ulcer. The original risk score calculation does not change, but now we add in another coefficient for the pressure ulcer, which coincidentally is the highest weighted coefficient. Mr. Jones now has a risk score of 3.934, so clearly he is expected to have higher than average costs. So on to our next poll question. Has your organization been successful with value-based care? Please select either yes, too early to tell, not yet, or it's not applicable. Hit submit, and while we're waiting for the answers, I can share that our provider performance at UPMC has been very successful, in particular with our own UPMC health plan. I attribute this success to the dedication of our physicians in learning about the importance of risk adjustment, as well as the use of technology, including natural language processing, which we're going to go into a bit of detail later. This way we can ensure that the risk scores accurately reflect our patient's severity of illness. So this is interesting. There's 32% say yes, that you have been successful. Another 23% are too early to tell, but some it's not applicable. Very interesting. So perhaps we'll address some of those features later. So I'm going to finish up by talking about, about how providers play a critical role in risk adjustment. It's a big shift for providers to have to document every diagnosis relevant to these risk adjustment models. Remember, and I'm old enough to remember, back in the paper world, where we only had to put one diagnosis on our claim in order to qualify for E&M billing. But in the risk adjustment world, providers need to document and put on a claim all conditions that coexist at the time of the encounter and require or affect patient care, treatment, or management. If you have coders, coders are not allowed to code conditions that appear only in a problem list or past medical history. There has to be evidence that the condition is currently active, and the provider must show meat, that you've monitored, evaluated, assessed, or treated. Provider documentation is often plagued by two common problems called undercoding or underdocumentation, which can lower your risk score. And I'm going to show an example of that. So here is an example of physician undercoding. At UPMC, 80% of our outpatient notes are coded by physicians. We do not have coders who review the claims prior to submission, but even if we did have coders, many coders are not familiar with the rules for risk adjustment. That requires specific training. But remember, providers only need one diagnosis for an E&M billing. And here's a clinic note from one of my partners, and you can see that the diagnoses that she recorded are memory change, hypertension, a flu shot, and dysuria. But buried in the documentation, I hope you can see, which is circled in red, is a valid HCC diagnosis of CKD stage 4, which the provider states is at baseline. CKD stage 4 has a significant weight in the CMS HCC model, so this is a diagnosis that you do not want to miss. But this CKD diagnosis would have been missed unless we had not used a tool such as natural language processing to pick up this diagnosis and add it to the claim. The next slide illustrates underdocumentation. Here, the provider writes, Mrs. Jones is depressed. This translates to F32.9 major depression single episode unspecified, which is not a CMS HCC diagnosis. However, if the provider had written Mrs. Jones has recurrent major depression, then this translates to F33.9, which is a CMS HCC. So how can providers remember all of these rules? Well, it isn't possible. This is why you need a tool such as NLP to identify documentation that is incomplete or not fully specified so that you can more accurately portray your patient's illness. If we see this documentation, we can query a physician to obtain the more specific documentation that is needed. So now I'm going to turn this over to Adam to discuss how to get complete and accurate risk adjustment.
Thank you, Dr. Towers. So this next series is really around helping organizations who are new in understanding risk adjustment, the impact that it has, and provide some practical guidance as to where to get started and how to ultimately succeed in what we refer to as complete and accurate risk adjustment. So first, as we take a look at the various populations, we saw very early on the 90 million lives that are in spread across the Medicare, commercial, Medicaid populations themselves. And the impact that risk adjustment has is variable. And so the real challenge here is how does an organization who's responsible and the physicians who are responsible for maintaining and understanding all the impact that risk adjustment has define a consistent process by which a reliable capture of risk adjustment is done consistently across those, even though the impact of risk adjustment itself is variable. So just to look at the variability here, what we've done is we've isolated down to just the Medicare population, and we've modeled a 10% increase in risk adjustment across the various arrangements. So in Medicare Advantage, the pure impact of increasing the risk capture by 10% is equivalent to $840 per beneficiary per year. In the next generation ACO population, where there's both upside and downside risk, greater opportunities at 3% improvement cap, a 10% improvement in risk capture is equivalent to $268 per beneficiary per year. And you can see the other programs, the logical description of how those are derived are listed underneath of those. I think this content will be made available as a recording for you to refer back to, but you can see that across the various programs, the impact that risk adjustment has upon each of them is different. So logically, you should assess where your organization is across each of these various programs in the acceptance of value-based care arrangements and identify whether this is an ideal opportunity for you to experience success and be perceived as highly efficient provider of care. This leads us to our last and final polling question. The question is, what is your biggest challenge in managing your risk-based populations? The options are analytics, access to data, workflow, or provider engagement. I'm sorry, there was an additional add, or risk adjustment expertise. We'll give you about 30 seconds to go ahead and respond.
I would have to say we should have one that says all of the above.
All of the above.
I think there's some that, before we started on this path, we needed all of this information. And, right now we continue to work on that. So it's certainly something that, I think all of us can benefit from. But I'm curious to see what people will pick as their top priority.
So let's take a look at the results. Provider engagement is the top. Not surprising.
Not surprising.
So provider engagement is key. We will hone in on that for the rest. Second, not far behind is access to data. And this was clearly called out in some of the AMGA Taking Risk 3.0. Some of the impediments to the ability to take on risks are really access to that claims data. And we'll talk about how you leverage the holistic patient record for this purpose. So at Health Fidelity, what we have done is defined an overall risk capture maturity model. And not surprisingly, many of the top level answers from that previous pool are listed on here. And the way that you can interpret this is the opportunity and ability to take your practices that you are leveraging today and really understand where you are and what are the opportunities that are still there that allow for the complete and accurate risk adjustment. So things that are listed out here, one would be the use of technology, right? It's very standard. This is a manual process of review. That is a low maturity model, yet it still has a significant effect upon your overall risk capture. Data acquisition and management, going from the top down, is really around how you leverage that holistic patient record. And so this maturity model is not built and constructed to say, I follow within one of these boxes. Really the way that you should be looking at this is the ability to identify yourself, where you are in each of the horizontals that are here, ultimately driving towards the effective and efficient capture of risk adjustment, which we believe is ultimately through provider engagement at the point of care in your natural workflow that exists inside the electronic medical record system.
The Holy Grail.
The Holy Grail. So for those who are interested in looking at a risk adjustment strategy, the first three things that we recommend an organization begins with is first, baselining your risk. And we will give you in the follow-on slide some practical approaches to which you can identify a baseline, stratify the risk of your population, and compare yourself to peers within your area to assess your overall performance. Second would be the identification and appropriate construction of a workflow that allows you to completely and accurately capture the overall risk factors that are present. There are many participants that need to be at the table for that. We would recommend these are going to include finance, operations, revenue cycle, and quality as a beginning point. And really what you want to do here is make sure that the workflow process itself is consistent and is measured, right? So that's a very, very important thing that we want to add in here, is the ability to actually measure the effectiveness that a workflow process is yielding in terms of overall productivity and impact to the RAF score. And last but not least in this is certainly that provider engagement, right? Provider engagement needs to be highly trusted, timely, simple, and measured in order to be able to succeed. And then lastly, we'll round out with the ability to measure and monitor performance. What are some of the KPIs there?
I would add one other thing, and that is compliance, because we always want to make sure that we're doing complete and accurate. We're not trying to upcode. People are, obviously reluctant to put their name on the line for a diagnosis they don't feel comfortable with. So again, we make sure that we enforce very complete, accurate, and compliant processes.
Well said. So if we begin to look at item 1 here, this is really around how do you establish a baseline. And I'll actually go to the right graphic first. Dr. Towers actually allowed and agreed for us to share and convey her risk score. And the data set that is used here is actually adapted from the Medicare Chronic Conditions Warehouse. And so this is really to say that everybody who is listening on the webinar today can go out and identify, has access to the public use files from the Medicare Chronic Conditions Warehouse. While it may be a bit latent, in how it's used, I think the most recent data is 2015 dates of service that would be used for your 2016 risk scores. However, you have access to that information, and you can very quickly go and identify for all of your providers who are in your community what is their overall population risk. So what we've done here is just identify that Dr. Towers, her actual population risk is equivalent to a 1.612 overall RAF score.
And I was sad about that because I thought I took care of the sickest patients, but obviously I didn't do it well enough.
So that's it. And to all the providers on the call, every physician believes that they are caring for the most sick population. And so the RAF score, the ability to affect risk adjustment, is your opportunity to truly portray that. Beyond there, what we did is looked at her colleagues and her immediate practice peers, right? Identifying other like physicians, other like providers to the population that Dr. Adele Towers is serving. You can see the colleague 1 was actually doing slightly better in the overall risk capture. Colleague 2 was actually lagging behind. So that represented the opportunity. And I did put both the PA average as well as the US average from the Medicare Chronic Conditions Warehouse directly on here so you have it for a reference point.
Yeah, thank you.
On the left-hand side is the exact same information, looking at this from a prevalence as well as reconfirmation rates, right? The low-hanging fruit and the opportunity to really affect the overall risk score is making sure that you can measure consistently the overall reconfirmation rates of those conditions that are in fact chronic, persistent conditions themselves. And so what we've done here is looked at this by overall HCC category, COPD, vascular disease, diabetes with complications, et cetera. Looked at the overall percent of the population and then the reconfirmation rates. So this is something very tangible, very practical that you guys can be doing today based off availability of the information that is currently known inside your EMRs, inside your population health management tools. You have the ability to really assess this and stratify and say, I can now identify, for example, in this data set, that congestive heart failure is one of a significant challenge. Vascular disease, again, is a very significant opportunity for this organization to focus on what they need to do in order to increase those reconfirmation rates.
So we can expect that maybe morbid obesity may not be valid year after year because people can lose weight. It is possible. But certainly something like vascular disease and COPD, we would expect to not go away.
So the next set of slides are really going to focus in on what are the necessary components and how do you facilitate an overall process. And we would recommend that success requires looking at data holistically, right? The overall HCC capture, overall the improvement or the success in value-based care is also dependent upon quality metrics. Workflow design is a necessary process here that needs to be done. It truly is change management, and we'll talk about what those workflows are. Provider education, as Adele said very early in the conversation, one of the keys to success here is making sure that the providers not only understand what is risk adjustment, but the way that it affects them individually, so that they are encouraged and incentivized in order to be able to capture the risk. And lastly, we'll take a look at some of the tracking and trending of data that lets you know how well you are doing. So step 1 is really around how do we establish this holistic patient profile. And really, each individual patient story is a collection of disparate data sources. There is information that is conveyed through medical claims and medications, lab values, even the care management assessments and health risk assessments that are being done all represent the entirety of the patient's risk factor. The one that is bolded here is actually the medical record documentation itself. And what we're going to do is understand how development of a centralized registry of the clinical presentation lifestyle according to the medical record documentation enhances the overall completeness and accuracy of risk adjustment. The first thing that must be done here, right, in order to establish holistic is, yes, you want to pull in all that claimant information, the lab values, as well as the medications, but you also need to account for those unstructured notes themselves, the physician narratives that are created that are telling that individual patient story. The processes that are leveraged today are typically manual in nature, right? There are abstractors that are sent out, and they are looking into each individual record one by one and not through a managed process itself. And there are technologies that have now emerged that allow you to integrate the information bidirectionally with the EHR. So first thing to tackle here is optimal record retrieval through technology. That's a one-way integration. And then we will talk about how we do a bidirectional integration where we can actually push these back to the various EHRs. The Health Valley, you can see the list of organizations that we've integrated with in the past. So if your organization is using one of these electronic medical records, we have already connected them up, and we have the ability to establish that holistic centralized patient record upon which risk adjustment analytics can initially be derived. The importance of the medical record documentation itself is due to the fact that 70 to 80% of the information that is known about a patient is only conveyed through these notes. There are details regarding the patient's care that are only found in the unstructured narrative of the patient record and not found through any clinical means. And so our approach to this is using a clinically oriented natural language processing engine that allows us to understand complex jargon, variations in expression and style, organizational specific language, even abbreviations and shorthand, and can actually identify what is truly something that's been copy and pasted versus a new narrative from the provider. However, not all natural language processing engines are equal. This is much more than just pure text matching or the identification of mentions within a note. And really, getting back to that meat criteria, you have to identify the evidential support that the condition is being monitored, evaluated, assessed, or treated. So we can look at a very simple example here where you see AF inside of a unstructured note that a provider had authored. You have to ask yourself, what does this really mean? Is this a patient's initials? Is this atrial fibrillation? Or is it amniotic fluid? Right? Only one of those has a significant relevance into risk adjustment, so you have to go through a process of disambiguation. And natural language processing is really that technology that, one, allows you to structure this, but two, contextualize it to an individual use case.
And you want to make sure it's not in the family history. I mean, not only does it have to contextualize the text, it has to understand where it came from, and what part of the note. So yeah, it's really critical to choose correctly.
So here's a depiction of what this overall process looks like, where you're aggregating the information from the electronic health record, in addition, combining it, blending it with the administrative claims data, creating a holistic patient profile. This allows you that opportunity to establish the baseline, as we talked about, identify the opportunities that are present, and stratify the overall opportunity based off of confidence, right? Again, you have to put highly trusted and accurate intel in front of the providers themselves to capture, and how this becomes enabled through workflow applications, thus ensuring the complete and accurate capture. On the provider side, we believe that this breaks down into three fundamental workflow areas themselves. One is what we call the pre-encounter. And so this is all the work that needs to be done around who you're going to outreach, do they qualify for an annual wellness visit, how are you going to make sure that the right patients are seen, and it's really driven by the overall confidence and stratification of the opportunity. But then you also have to do an additional step to make sure that those can be highly trusted and accurate, right? A diagnosis that is found in the justification of why a lab was ordered has low credibility, right, comparative to the same value itself being found in the medical record documentation of the provider for whom you're serving the gap. Let's allow that synthesis process in what we call pre-encounter identification. The next step is really around during encounter, or this is the point of care. It allows you to deliver the verified gaps in care and documentation, provide the assistive documentation tools to ensure that the conditions are being accurately and completely documented, which is truly the role of the provider in this overall process. Leading to the third step, which is really post-encounter encoding. I can tell you right now, up to 30% of the chronic conditions that are present within a given organization's baseline are already being documented and recorded. They're just failing to make their way onto the bill due to the point that you made earlier, Dr. Towers, that 80% of these encounters are only ever touched by the provider. And you don't have to do this all at once, right? A phased implementation allows for continuous improvement and early recognition of an ROI, most specifically beginning with that post-encounter phase. Understanding that, if we think about these three phases of pre-encounter, during encounter, post-encounter, each organization has to progress at their own pace of which this will be consumed. We put this on a scale. It says, there are ways in which you can begin with a low level of integration, but still accomplish all three of these phases that we believe are essential. Right? In a low pre-encounter, this could be a manual outreach, right? How are you able to engage with both the providers as well as the patients by creating a targeted list? Likewise, worksheets are still able to be fulfilled in the during the encounter. It's a low level of optimization, a low level of integration, low cost of entry, but it's something that can be done all the way up to a high optimization where there's direct EMR documentation, right? The suspected opportunities, the gaps are being directly presented, actionable inside of the electronic medical record itself, and the same is true on the post-encounter. The common basis of this is really those two things that you see down at the bottom in blue. The data acquisition, making this holistic patient record, the use of NLP to understand that 70–80% that is unstructured, and the use of machine learning to ensure you have a highly confident and trusted gap detection that is occurring. And the other is the business intelligence itself. How do you identify the algorithms that allow you to appropriately stratify and target those challenge areas?
Can I just emphasize that providers do not like to be bothered with low confidence suggestions. So that machine learning intelligence is so critical to making this acceptable to our providers.
So what does this actually accomplish in holistic risk capture? The state of the industry is most people are leveraging administrative data in this process, either historical billing, claims information coming through payer partners. What we are proposing is that you actually augment this with the addition of NLP-enabled clinical documentation. So you're looking at that entire patient history, all the provider notes, all the corresponding lab values, medication lists, et cetera, that are contained in there. And the way that you can view this is on accuracy and completeness. If you use the claims-based information, there's a moderate level of accuracy as well as a moderate level of completeness. There is still information that's contained inside of the clinical record that is never making its way into the billing data or into the claims information. As you add in the NLP-enabled documentation, what you're doing is you're improving both the accuracy of that which has been identified through administrative data by supporting it, right? So a patient who's known to have diabetes in the past, we're actually able to pull forward all the associated information that is contained inside the medical record that further supports that, thus increasing the likelihood of overall acceptance and that provider engagement. Next thing that we would add on here is once you have all the analytics, it really requires a synthesized process. That there's a care team review involved in the pre-visit evaluation, as well as a documentation specialist review that would occur after the visit has been conducted that allow you to, again, have a total effect on these measures of both accuracy and completeness. So this is a quick example of the post-encounter application. What you see on the upper right hand is what the provider has previously billed, right? Essential hypertension. This time they caught the CKD, hypercholesterolemia. However, the physicians are not trained on the appropriate coding, and nor do we want to turn them into coders, right? Their role is the clinical documentation. And so what we do is by augmenting it through NLP, we actually identify that there's a more specific reconcentrated type 2 diabetes mellitus with diabetic chronic kidney disease that can be supported, right? There was modification to the coding guidelines of which have occurred, which have all been injected into the system to be accounted for, that allows you to capture a higher order HCC than what is currently known. So if you allow this claim to go as is, it would result in only HCC 19. The suggestion that we are making is for HCC 18 that would supersede it, equivalent to approximately $2,300 of incremental reimbursement. Now, there's several options that get presented here. One is the opportunity to identify those which can be immediately added to the bill. In other words, the documentation, in this case, physically supports. You add it to the bill. Therefore, you can affect all populations, including that high-volume Medicaid population, where there is no supplemental process. You have to get this information on the claim in the first place. The other option is for that of a query, right? So where there is clinical indication, absence of the definitive diagnosis, or incomplete documentation of that meet criteria, you have the opportunity to query and go back to the provider, seek the additional clarification, and close that opportunity. This is some common experience that we see, right? So if you just look at the coding process itself, this looks at 5 clients of Health Fidelity. We've identified what is the actual error rate. And as we look at an overall population, this is HEC's measured per 100 members that we look at. So basically, in organizations that are performing well, we identify 1 HEC in every 10 members. It scales up depending on how well you are doing in capture today. You can see client 4 is at 37 HECs for 100 members.
So this is really the benefit of natural language processing. It must be really tedious for coders to have to read without the use of a tool in order to capture these diagnoses.
That's absolutely it. And the ability to have NLP target, right, and take out that waste that is present in doing a holistic review is really, really important. And so this is a chart that looks at it and says, hey, if you were to look at all the entire population, what is it that NLP identifies and further machine learning stratifies to allow us to target, right? In this case, 10% is a high opportunity, right? Those are the ones you immediately want to take action on. 20% is the low opportunity, and 30% is the some opportunity. So you have the opportunity to stratify and focus on those specific areas. But the more important piece here is that 40% of the overall data that was processed that would result or would necessitate a human being to review is able to be filtered out. And these could be controlled, right? Given your risk tolerance as an organization, where you want to be, what you're given productivity and resources and operations look like, you can use this and leverage this stratification to make sure that you're making the most effective use of your time. So this is a result of a pilot of a provider group. They are a Medicare shared savings program, as well as were at risk with several Medicare Advantage payers. What we did is we loaded the member records into the application. Basically, we facilitated that chart review just as you saw the post-encounter screenshot, and here's what has become identified. 6% risk score improvement just by coding the risk adjustment gaps. So if you equate this back to what we saw, right, a 10% improvement for Medicare Advantage is $840, so on and so forth for the various types of arrangements. But just what was the codable opportunity was a 6% risk score improvement. The other category is that which needs to be queried and facilitated, right? These are what we call the underdocumented conditions. There was clinical indication that was present that would indicate the presence of this condition. It was supported, but we don't have that complete meet documentation that would allow you to go ahead and capture this. That represented an additional 8% opportunity. And you can see how we use these and identify them as either a pure suspect, which we call opportunity category 2, or an immediate query opportunity for category 1 based off of its presence. So in summary here, risk adjustment analytics, right? The combination of data acquisition, the ability to integrate bidirectionally with the EMR, plus NLP creates the most complete and accurate risk adjustment analytics. Some pragmatic approaches here. One is prioritize the members who need to be seen, right? The ability to identify what is it that are the outstanding opportunities, where are those concentrated across your provider network, within specific sites, medical groups, who needs the most improvement. Conduct a pre-visit assessment for chronic conditions. This will ensure that provider engagement that the pool said is the most important thing, trust and accuracy, right? If you result in a high level of inaccuracies out to the provider community, you're going to have a lesser overall engagement, acceptance rate of the provider community. Next is you have to present the suspected conditions to providers. They are not trained in the holistic risk adjustment, nor do we want them to become coders, right? And so the ability to make it very timely and simple for that provider who wants to do the right thing to do the right thing. And you do that through the point of care notification. Use NLP to finalize coding. Again, 80% of the outpatient encounters were only ever touched by the provider. The improvement that was experienced there, right, has been 30%. 30% improvement of chronic condition capture associated with just conducting the code review itself. I didn't highlight it earlier, but NLP does identify the non-compliant diagnosis. If you go back to the screenshot, there was a little delete button. And so that allows you to do a full two-way review. So as you're looking at the record, you're seeing what it is that the provider billed. There's a lot of history of cancers. There's a lot of strokes that in the outpatient setting that the NLP will identify and allow you to make sure, again, from a compliance perspective, that you are accurately reflecting the overall disease burden. And then physician engagement and education are all too important. We have quick reference guides that we push out to all providers, but the more important aspect here is helping them understand how risk adjustment affects them, the way in which they are measured, and the overall efficiency by which they are compared to everyone else. So these are the 4 core components of how to succeed. One is making sure that you have the appropriate workflows defined, that you're able to capture the overall revenue opportunity to reinvest back into the care that you're providing to your communities. Compliance absolutely has a seat at the table, making sure that you are doing that full two-way review. This is not about upcoding, it's around completeness and accuracy. And lastly, are you using appropriate analytics and reporting on the holistic patient chart to affect the risk adjustment performance? So with that, I know we're running a few minutes behind the schedule. We'd like to go ahead and open it up to any questions that the audience may have.
Thank you, Adam. As he said, now we'd like to open it up to the audience for questions. As a reminder, please use the questions section in the GoToWebinar panel to submit your questions. The first question, what do you think is a reasonable time frame to see improvement in risk scores after implementing new workflows or technology?
Yeah, certainly. So within risk adjustment, depending upon your population, you can expect to see a 6% improvement within the first 6 months. That is a fairly typical. In areas where you're allowed to even do retrospective review, you can reduce that even more significantly. So if you are, reduce the time. If you are in a Medicare Advantage payer partnership, shared risk, capitated, even shared savings arrangement, and you want to be able to go back and identify that appropriate baseline of risk according to the unstructured information, you can conduct a retrospective review that was under the moderate optimization and integration route, and you can do that in as low as 30 days. That pilot that you saw there was an actual 30-day total turnaround. From the time that we got the data, we reviewed all the members, we identified that 6% improvement within an MA payer partnership.
No, MA just provides a longer time frame, so that really is very accurate.
Can you talk a little bit about what the typical challenges or objections are that you encounter with physicians when they're taught more about risk capture, and how do you address those?
I'll take a first stab, and maybe Adam can add to the end there. But providers obviously are not taught this in medical school. We're not taught that it is important. But I think you have to appeal to, again, the altruistic side of medicine, which is that we're there to take care of our sick patients. And how can we accurately say we had a sick patient? As you saw, I thought I took care of the sickest patients, but my risk score was not the highest. And perhaps it's because I did not accurately reflect all the diagnoses that I am treating that patient. So you appeal to that altruistic side, but ultimately providers are listening to how the risk score impacts their finances. Whether they're in MIPS or in shared savings or in an ACO, that risk score often determines what they're paid. So again, I go for the altruistic first, but the bottom line is it does impact their finances.
Yeah, I would just add to that, to put myself in the provider's shoes, what I've heard is you have 15 minutes to spend with the overall patient, right? And the first 2 minutes are spent acclimating to what the situation is. The second 2 minutes are spent in the interrogation back to the patient as to what are the current issues, the physician's agenda that they want to be able to carry. That leaves a very, very small amount of time to provide all the other things, right? we're just adding risk adjustment into this. And so for that, it is very, very important that is a simple process, as easy as possible for the provider.
At the point of care.
At the point of care.
So
and the second thing is the ability to actually measure and relay back to them and say, hey, well, here is the impact that this is actually happening. How does this have an effect on overall things like your medical expense ratio? How does this affect your overall measure of efficiency of comparing your actual expenditures to the overall expected expenditures? And again, that competitiveness.
Oh, yeah.
How do you share and convey, here's how you are doing in comparison to other like providers of care?
Yeah, good points.
Yvonne says that they use Epic and they've leveraged the MA registry to help with HCC recapture using the HCC refresh needed BPA, and is asking if the NLP can be integrated with this BPA to help capture those diagnoses.
So yes, in fact it can. I'll ask Adele to speak to the work underway at UPMC to do that. What I will say is that the NLP, in addition to the common registries there, allows you to access that unstructured information. It really does two things. One is it allows the identification of 12 to 15% more overall risk factors that are present, have never been known to exist, or are not present in any structured data field that is present in the EHR. Opportunity two is really the ability to enhance the overall engagement rate of those providers by giving them the visibility into the supporting evidence that you have that represents why this is in fact a true and existing suspect. If you just take a lot of that and try to put it in front of the provider, example of cirrhosis, right? On a CT scan. That can only be identified through the unstructured information. I was actually thinking of something more simple that was identified from an external provider that's not known to exist at all inside of your EHR. It's very unlikely that a provider is going to accept that because they can't see it inside of their own Epic environment, in your instance, or inside their own EHR. However, if you can find it in unstructured data through those clinical notes that indicate the presence of it, you're far more likely to increase the overall acceptance rates of the providers. Do you want to speak to
what Adam is referring to is that we're in the process of developing a point of care tool that will not only incorporate the current BPA alerts for diagnoses found in Epic problem list, past medical history, or prior claims, but in addition, they will identify these diagnoses that are present in the unstructured data. Like you said, it could be a radiology report, it could be a PFT, it could be an echo, it could be any other unstructured format where we're finding other clinically relevant diagnoses for this patient that have not been previously attributed. So historically, we find with natural language processing 10 to 15% more diagnoses that are just documented by providers that are in the unstructured notes. So those diagnoses are significant, and we have to point those out to providers. But in addition to that 10 to 15%, there's another percentage. You want to give I'd say another 10% of diagnoses that are in the lab data, in the radiology data, in the other procedural data that, again, have not been attributed to that patient. So we are creating a point of care tool to provide all of these to the provider with links to those sources of information so that they can feel confident in addressing that condition at the point of care. And simple, that's the other goal.
Okay, one more question. Has NLP reached maturity in terms of accuracy and completeness?
Yes, so it absolutely has. NLP, I would say if we went back even 3 years ago, it was at a level where it was more investigation and research and development oriented. But because of the emergence of machine learning capabilities, it has allowed us to very, very quickly improve both the sensitivity and positive predictive value of the application. Right, so out of the box are the sensitivities that we are experiencing of identification of risk factors that are in fact present is high 90s. Anything less than that would be unacceptable. But really, the inverse of that is, well, how do you make sure that the insights that you are putting in front of the end users are going to result in the definitive acceptance? And the ability to leverage confidence levels from machine learning, we set a bar, right? The minimum bar that we would ever utilize for an organization of those NLP insights is 70%. we must be at least 70% confident, and that goes through an internal validation process before we ever put it in the hands of the client.
Which is automated. It's an automated process,
yes,
to be clear.
To make sure that we're able to hit that mark. If we can't internally hit that mark, it is not going to get released as the opportunity to continuously improve the overall PPV. So our end objective there is that you want to have a highly sensitive system. You need true NLP to do that. That is the most important thing, is then followed by the overall positive predictive value of which the insights that you are generating. Any engagement with the provider necessitates 70% or up.
Right. So what Adam means by the machine learning is that we just don't take a text finding of maybe aortic atherosclerosis on a CT scan. We're going to be looking for evidence of treatment for high cholesterol, evidence of symptoms on physical exams. So that machine learning pulls in all the elements of the suspected condition to give a more accurate confidence level before providing that to a provider to say, hey, can you validate this condition?
Okay, great, thank you. That was our last question, and so with that, we'll conclude the webinar. I want to thank everyone for joining us today, and thank you especially to Dr. Powers and Adam for the interesting and informative presentation. As a reminder to attendees, keep an eye out for our follow-up email, which will have links to the recording of the webinar as well as the PDF version of the PowerPoint presentation. We look forward to seeing everyone at our next HIS Talk webinar, and we hope you enjoy the rest of your day.
Thank you very much.
Thank you.